Hello, and welcome to the Alabama Public Health Training Network. I'm Carolyn Byrne, Director of Governmental Affairs and Community Relations at the Alabama Department of Public Health. Thank you for joining us today for our program, Health Literacy Training. We are delighted to have you and just want to let you know if you have any questions about anything pertaining to the discussion today, please call or email us during the broadcast. The phone number and email address is on the screen, and we will also put it up again later in the program. Also, the handouts are available online. You will need to register for this program in order to access the handouts. Alabama has been delighted to have Joy Dupree as our health literacy specialist for many years. She worked with several governors and several academic institutions on health literacy. And I just wanted to share some of her letters behind her name. She is a PhD. She is an advanced practice registered nurse. She has a master's in nursing education, and she's a women's healthcare nurse practitioner. And during her journey in health literacy, I have worked with Joy, and we're just delighted to have you, Joy, and just want to turn the program over to you. Thank you for being here.
Thank you so much. It is my pleasure to be here with you today, and the camera is straight in front of me. Okay. It is my pleasure to be here with you today to talk about one of my favorite subjects, health literacy. I began my journey with health literacy many years ago, around the 2000, around the turn of the century. And when I first began, I never dreamed I would be still working in that field 20 plus years later. But this session today is really to give you an overall broad view of some of the specifics about health literacy. And there's an entire scientific community that has devoted 2 to 3 decades of their research to studying health literacy and creating all types of assessment tests as well as theoretical models and frameworks. So if you are someone that has an interest in learning more about how to use health literacy initiatives, feel free to contact me or Carolyn, and happy to connect you with those folks that could help you. Okay. So our objectives today is really a historical overview with the definition of health literacy, and we're going to describe the populations that are most at risk for limited health literacy. I want to bring to your attention that we no longer use the word illiteracy, and we have used the term low health literacy for many years, but now we are using it's more correct to use limited health literacy. So the scope of the problem is massive, and we'll talk about that, and then we're going to describe the socioeconomic impact. And the recommendations from the National Action Plan to Improve Health Literacy, which was developed around 2004, and it is a very, very useful tool. It's the summary, so it's only about 5 pages long, but it gives you a great deal of information of some of the steps that we need to take to make all of America more health literate. So I want you to think about, just for 1 minute, just close your eyes and think about, what if you woke up one morning and you found yourself in Russia and you did not speak Russian? And now open your eyes and consider looking at this photo and saying, oh, what a beautiful city this is. Let me go and get a tourist guide to help me. Well, they don't speak the same language you do. The literature that they give you, you can't read. You can't even read the back of a cereal box. And that's where most of our really low literate families and individuals find themselves. Low health literacy at the very lowest level is considered reading at or below a 5th grade reading level. The vast majority of Americans come somewhere between below basic and basic, and then there's limited, and then there's proficient. So there's really 4 categories. But think about how challenging that would be. So when you work with patients and their families, a lot of times they will come in and they will say, "Now, I don't have any questions," and many times it's because they feel very intimidated. We've been told over and over that patients prefer community health workers over anyone to work with them because they feel very comfortable with them. They feel like they're a trusted colleague more than a healthcare provider. And there's some videos online that will say, all that medical jargon is so intimidating to me. And so people will clam up and say nothing. Then they might go home and look online and find information that's not correct. And that's where a lot of misinformation and miscommunication comes from. So just imagine what it must be like for someone in that situation. So in the beginning, how it all began, in '74, S.K. Simons coined the term health literacy. It was the first time it ever appeared in print, and it was published in the Health Education Monographs. From '74 to 2010, there were a multitude of definitions written. There were more than 18 by the time we got to 2020. I think there were about 28 definitions. Among those agencies that had defined it included Health and Human Services, Institute of Medicine, the American Medical Association, the World Health Organization, Healthy People 2010. However, nursing was not among any of the groups. Well, I'm a nurse, and I've been very passionate about this subject for a very long time, and I was really terrified to think that my profession did not step up to the plate and say, we spend more time with patients at the bedside, we do discharge teaching, why aren't we included in defining this? So through the years, we now have some wonderful definitions that we don't need to continue to define it, but I do hope that there will be a shift where nurses get more involved as well as the other professional healthcare providers. Okay. So that then there was this is not coming. Okay. So how do we know what we know about the demographics? The National Adult Literacy Survey was created in 1993, and it was after legislation was passed at the national level for the Literacy Act of 1991. And that was in 1993 that they conducted the NALS. Well, the NALS, it was about 19,000 households randomly selected from all over the United States that really was just a scattering of any type of family or household you could imagine. But they didn't have a health literacy component with it, but they did survey math, reading, understanding of just simple information. And we did not have great outcomes. So it was repeated again in 2003, and it was the National Adult Assessment of Literacy. And that did include health literacy. And the sad part is that there was no improvement from 1993, and in some areas we actually declined. So the results was that, I'm sorry, this was what should have come up first. The National Literacy Act was signed into law in 1991 by George Herbert Walker Bush, who provided the funds for the national data collection surveys to determine the literacy levels of America, and that's where the NALS and the NALS came from. So the results was that very few changes were found. There wasn't a great deal of improvement, and there really has not been the funding to support that just in America. So we have not had another national survey on that. But the National Assessment of Health Literacy, and this is where the demographics comes in, 19,000 adults, it measured 152 tasks, that 28 were health related. Well, I told you about below basic. They can maybe circle the date on a doctor's appointment slip. So only 14% can do that. And some are not able to do that. And depending on what demographic some of our population comes from, it may be more dire. Our Hispanic population suffers more in understanding, as well as our African American population, particularly those in the rural Southeast and out in the very far western states, like California. So then you go from below basic to basic. And basic allows someone to be able to determine when it's okay to drink a water or whatever before a medical test based on short instructions. And about 22% of the population is able to do that. So you've got a lump there of about 36% of America that really, really struggles with understanding how to manage their health care. And then the largest group is the intermediate. These folks may or may not have a high school degree, but they may have a GED if they don't have a high school degree. And they know how to determine what time to take their prescription medicine based on the label. So you can see how it moves up just slightly depending on the level of education and their capabilities. Now, the proficient level is only 12%. And I would dare say that probably everyone in our audience today, as well as those of you who are viewing this online, fall into the proficient category because you were fortunate enough to have the opportunities to go to school and to learn math and reading and science. And basically that's what our discharge teaching, as well as any of our healthcare instructions, involve: numeracy and understanding of information that is written down. Again, this is the National Assessment of Adult Literacy. This is the one that had the health literacy component in it. And it addressed and assessed functional skills in clinical, preventative, and navigation. You can see we didn't change very much. You can see here we're at the below basic is 14% rather than I think it was 12% before. But if you go over to this side and look at the Hispanic, Native American adults greater than 65, you see these numbers really begin to increase. But then when you add the basic level, which is 22% or was at that time, that's a lot of what makes up our Medicaid population. And then the good news is we have a large number of our large amount of our population that do fall into the intermediate category, over half, and they absolutely, with enough instruction, can easily figure out and understand how to care for themselves properly. And then you have us and those that are proficient and maybe have been highly educated either in healthcare or other areas that they understand how to compute with math as well as read and understand. The intermediate category and the below basic and the basic make up 88% of the U.S. adults below the proficient level. That is nearly 9 out of 10 people. So Howard Koh from the Health and Human Services in the National Action Plan that I shared with you earlier and that you will find as a handout, he predicts that 9 out of 10 adults, no matter what walk of life they come from, do not completely understand their healthcare information. Well, you can be highly educated. Some of our studies that have been published in America relate to professions like engineering, our armed services. And when those people were measuring their health literacy, or their health literacy was being measured, some of them did not score very well. And it's not because they're not capable, it's because they just had not had the time to read it and understand it. So consider the fact that it's not necessarily that you're not capable, but that you haven't had anyone to teach you. So you have high capabilities of understanding it if somebody takes the time to work with you. And that is where we fall down greatly with our discharge teaching whenever hospital patients are released. Because I don't know about you, if you've been in a hospital lately or if you've had a family member or someone that you were supporting as a caregiver, but often you will be handed information. The nurse will say, I'm going to come back in a little bit and I'm going to ask you if you have any questions. And it's partly because they're so crunched for time. You know, we've heard all about the nursing shortages, and COVID-19 has even broadened our awareness of the challenges that nurses face. And sometimes they're on morphine pumps, which we know that is going to impact their ability to remember and understand. So we've got to do a better job of educating people at discharge teaching and then following up. And there's a lot of studies that are going on now and a lot of new initiatives going on. And I don't know if you remember, but several years back, the Centers of Medicare and Medicaid came out with penalties that penalized hospitals if adults re-entered the hospital within 30 days. Well, that was the impetus for a tremendous amount of work that was done in health literacy that many hospitals have implemented to make sure patients understood. They created lots of toolkits. One that I particularly like is the RED Project Toolkit. And that's not in your handout, but it was created at Boston College. You should be able to find it online, and it's all caps RED. Project. And what it does is it allows the nurse to tailor the discharge instructions to individual patients. It's not just a standard template that everyone gets. And so that has been unbelievably successful in the hospitals that have implemented it and really enforced it from the top down. There were 10 studies done with the RED Project across America. 5 were highly successful. Some of them cut their hospital readmissions in half. That was huge savings. They were the ones that had complete support from their administration all the way down to the basic level of employee. Even the front staff clerk is important to this process. So if you have someone that you know works in a hospital and they're considering trying to implement something like that, just make sure that they have a real clear understanding of the support that they have from the administrators that will be allowing them not only the resources, time, and space, but the ability to stay with those patients as long as they need to make sure they understand and follow up. So we did not have another national study, but a couple of years later, the Program for the International Assessment of Adult Literacy Competencies was testing everyone in the nation, everyone globally, I'm sorry. So although the U.S. did not survey or study, this was what we used to begin to collect information, and surveys were done in 2012 and 2014. What were the results? They were not very promising for America. We fell below most other industrialized countries internationally. And this is a snapshot of, you can't see at the bottom those tiny little names of those countries, but I'm going to show you where America is, right there. We are the wealthiest nation on earth. We should be at the very top of the scale on this measurement, but we're not. And we've seen that through our educational system. We know that many of our states have challenges with educating their children and they don't have enough resources. Current literacy rates for basic literacy nationwide, on average, about 79% of the U.S. adult population have challenges with literacy. So it doesn't mean they're not capable. It means they're challenged. What would be an example of that? Well, if a prescription reads, take 2 pills a day by mouth until gone, and doesn't spell out a time or when the dosage should happen, they may take them both at the same time, when in fact it's meant to be taking one in the morning and one in the afternoon. So our pharmacists are some of the greatest champions and advocates for health literacy. They do such an amazing job working with patients that have challenges with literacy, and we hear that over and over in studies that I work with. 54% of the adults have a literacy rate that means that they read at the 6th grade level or below. That was in 2023. Almost half. 6th grade reading level is about what most newspapers are written at now, at which they're written. Health literacy goes way beyond a narrow concept of health education and just individual behavior-oriented communication, and it addresses the environmental, political, and social factors that determine health. That was written in 1998 by the World Health Organization. What word right there brings to mind what we all hear a lot about now? Anyone from our audience? I know you know. The social determinants of health. So the World Health Organization was way ahead of the curve on this one. Kudos to them. Then there's cultural differences. But cultural differences really are part of every piece of healthcare. It is not the same as health literacy. So consider that when you're working with patients about the cultural differences, but also remember, culture does not equal health literacy. But I want to tell you a little bit about how the health literacy movement after 1974, when it was first coined, really took off. So in the early 2000s, Richard Carmona got a call. And a little bit about Richard Carmona is that he was a high school dropout. He was a first-born generation Italian-American living in the Bronx. And he will tell you, if you go online and watch some of his videos, he gives a wonderful presentation about his history. He said it was either prison or the military, and because he did not like school. And he attributes the women in his family to really making sure he was successful. So he joined the service, and he became a paramedic in Vietnam and just flourished in that role. He was amazing. He was wonderful. After that, he got back to America, and he was encouraged to go to professional school for healthcare, and he thought, well, I'll become a registered nurse, and he did. While he was a registered nurse, he was still encouraged to further his education and became a physician. Then he went on to be a surgeon, and then in 2002, or probably 2001, he got a call from President George Bush Jr. and asked him to be his Surgeon General. Well, he's a very salty guy, and he had some really choice language because he thought it was one of his friends playing a prank on him. But it was actually true, and it was because he had such an amazing sense of working with people. So you can see all of these different types of hierarchies in which he had been involved in throughout his life. He had a lot of common sense and knew how to talk to people. And that's a big part of what health literacy is about. He advanced health literacy efforts probably more than anyone. This is a photo of him. And this is from a publication that the Sigma Theta Tau International Society for Nursing publishes every quarter. And on the title it says, "Once a nurse, always a nurse." And I have always loved that about him because he's a very humble man, and he continues to work now, and he's in Arizona. So from his work, there was a seminal piece of material put out called Health Literacy, A Prescription to End Confusion. And the NIH really got behind this. There were tons of videos that were created that you can still find online. They look a little dated because the hairstyles have changed a little bit and the clothing looks a little bit different. But if you have a chance to go online and look at that, I encourage you to do that because it's real life people. It's not actors, and it's folks that were interviewed about how they feel when they go into the healthcare environment when they are low literate. And they're dressed very nicely, they speak very nicely, but some of them could not calculate or compute or read anything on their prescription bottle. And they often said, I feel very intimidated by those big words they use. It just makes me nervous. And so they just forget to ask their questions when they're in there, because if they're getting bad news, their anxiety level goes up so high. And what do we know about that? You're not really able to take in and absorb instructions when your anxiety level is high. So his saying is, as a former nurse trauma surgeon and public health director, I realize there is a wall between us and the people we are trying to serve. Healthcare professionals do not recognize that patients do not understand the health information that we are trying to communicate to them. We must close that gap between what healthcare professionals know and what the rest of America understands. And I love that quote because it says everything about what we're trying to do to improve health literacy. So what is health literacy? Probably the most widely used definition came out with the Patient Protection and Affordable Care Act when President Obama was in office. And it defines health literacy as the degree in which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. And let's see, I'm trying to go down there. Health literacy is a central focus of Healthy People 2030. This is a link that you have access to this PowerPoint, I believe, in your resources. We're not able to open these today, but I want you to click on the embedded links when you have time to go back through this. But from this document of Healthy People 2030, they went a little bit further. Because one of the things we've realized over the last 15 years of studying health literacy is that it's not just about personal health literacy, it's about organizational health literacy. Remember when we talked about those hospital readmissions? Well, organizations have begun to step up to the plate and really make a difference in how they are educating people at discharge. But personal health literacy is the degree in which individuals have the ability to find, understand, and use information and services to inform themselves on how to care for themselves or their family members. Organizational health literacy is probably the most important, in my opinion, because it is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. You heard me enunciate equitable, because we hear a lot now about equality and how health literacy is really linked to equity. And so if we don't take the time to spend with our patients, we are not enabling them to find, understand, and use that information. And, you know, you cannot underestimate the value of the teach-back method. And nurses are taught this in school, but it's a real quick learning activity. And even though they are taught about teach-back, they often don't really utilize it properly. And it only recently has the medical profession begun to include teach-back in some of their curriculum, and that's due to Clifford Coleman out of Oregon. He is a physician that has really championed many research projects related to how physicians communicate with patients. And he is a huge advocate for putting health literacy education into curriculum for medical doctor profession curriculum. So, Healthy People 2030 has one overarching goal of Healthy People 2030 that describes health literacy and health equity and how they intersect. And it is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being for all. And if we are not spending time with patients that we know have challenges, we will never have health equity. So please, whenever you are with a patient, give them the information, get them to go over it with you. If they can't read it to you, that's a red flag already that you know that they may have a challenge when they go home, but they're very embarrassed sometimes if they're not able to read very well. And so we have to teach it to them and then ask them to tell us in their own words what their understanding is of the directions that we've just given them. And it may take multiple iterations of doing that and going over it, and then following up with them by phone. You know, that costs very little, and it can save a lot of money for our healthcare system. In plain language, health literacy impacts patient understanding, patient compliance, it impacts patient outcomes, and you cannot judge a book by its cover. This is my favorite clip, but I'm not going to spoil it by telling you what it's about, but encourage you to go in and look it up when you click on this, when you look at the PowerPoint presentation online. It is a 30-second, very cute snapshot of what really just says this lady didn't know what she was supposed to do. Disparities at risk populations associated with low health literacy include the largest segment are those that are 65 years and older. A lot of people don't understand that. They really first default to those that don't have a high school education or those that are immigrants, but it is those that are the largest portion of our population, those that are 65 years and older. And we don't really have any great data telling us why that is, but the theory is that they've been out of school longer than anyone else. They grew up at a time that whatever your healthcare provider told you, you just did it. You didn't question it. You had no, they were the boss and you just did what they told you to do. And things are very different now. And if you get 12 minutes in your individual patient assessment with your healthcare provider, you've done pretty well. That 12 minutes doesn't go long enough for you to really be able to cover everything that's on your mind. And unfortunately, our healthcare system has become so burdened with lack of physicians as well as lack of nursing professionals that there's just not enough time. And those that are 65 years and older also have some cognitive decline. So by 2030, it's estimated that 1/4 of all U.S. adults will be 65 years and older. We've got a lot of work to do. Those disproportionately affected by low health literacy that are the ones you would obviously think of are those who are poor and live in the southern and western regions of the United States that do not have a high school degree or a GED. They're cultural and ethnic minorities that include refugees and immigrants and non-native speakers of English. So if they grew up speaking English in their household, they're going to be more literate and health literate. General literacy in Alabama, it's estimated that over 500,000 people in Alabama, the adults, lack basic literacy skills. The adult population in Alabama with limited health literacy is estimated to be as high as 57%. Now remember, limited health literacy really puts them into a couple of categories. It's below basic, basic, and some of that intermediate. But treat every patient just as you would the other. And there's another very popular and very well-known program that came out after the HIV epidemic, and it was called Universal Precautions, and it was about bloodborne pathogens. Well, the health literacy community also has a similar project that they say, use universal precautions, assume every single person has low literacy, and go over every single bit of information with them. Don't assume anything. And when you've gone over it with them and they can repeat it back to you, that's fabulous. It's not rocket science, y'all, but it's costing us that much, and the economic to the United States taxpayers is overwhelming. It is estimated that a minimum of $238 billion are spent already in overburdened healthcare system because of low health literacy, and approximately 28% of hospital admissions of seniors who take more than 5 or more medications per day are the reason that some of them have adverse drug events that lead to hospitalization because they don't understand how to take it. We see that a lot, especially with our Hispanic speaking population that, because they usually have been more in the workforce and they do understand some language and some of the meaning of some of the words. But for instance, ounce is once in Spanish, and that's 11 instead of ounce. So we need to be very, very careful and make sure that we have explained it well and they have returned that demonstration to us that they fully understand. There's a great little vignette in those NIH videos online of a construction worker in California who had fallen and he went to the hospital and was hurt. And they gave him some pain medication to take home with him, and it had take one as needed, and it had like 10 or 15 Lortab or Norco or whatever in it to help him get through the week with his pain. Well, he took one. His exact words were, "I took one, and it didn't help, so I took another one." And he just kept doing this like every hour. And before the night was over, he was almost comatose and had to be taken to the hospital. And it was all because he did not understand that he could only take one every so many hours. That was left off of the prescription. So there's a lot of work being done in the health literacy community around prescription data and labeling. And California actually has implemented and enacted a law that requires certain special fonts and certain different types of wording on their prescription bottle. And all you have to do is look that up and say prescription bottle labels in California. But the other way you can look at it is through one of the large trying to think of the best way to describe this. One of the large consumer organizations that we all go and shop, and they have pharmacies within that. Can I say the word? It's Target. Target's pharmacy decided to implement this on their own. And if you look at your Target prescription bottle, it has different colors on it depending on what time of day you're supposed to take it. It's very well done, and it was patterned after what was adopted in California. So kudos to Target for going ahead and doing that. And the reason there's been pushback is that all of this software was developed years ago and is very expensive to redo everything. But I believe eventually we will see that adopted nationwide. So how does low health literacy impact patient care? We've talked about this a little bit, but it really decreases their ability to understand medication labels, and that's one of the most important parts. If I bring anything home to you today, that's what I want you to remember, and particularly in adolescent populations that have children very young. Because if they've left school and they're a caregiver for a child and they're responsible for their medication administration and they don't understand the difference between a tablespoon or a teaspoon and they don't have a measuring cup that was given to them, they're using their household spoons, and that can be disastrous. So think about that with the population you're dealing with if it's adolescent. It decreases their likelihood of receiving preventative care. Why do you think that is? Well, they delay going in, and they're not as proactive because they don't know what the right questions are to ask, and they're embarrassed about that. It decreases knowledge, confidence, and skills to manage chronic disease. Very much influences the increase of the emergency room use and avoidable hospitalizations and readmissions, and it increases diseases related to complications and comorbidity and mortality. Resources. How to assess individual health literacy of a patient. You will find in your resources, in the modules that you have before you, these tools, and they are easy to use. They are very well vetted. They have been researched and validated for years. And the one I like to use is the brief because it has 4 questions. It's very simple, and you actually have an example of that in your toolkit. So bring that out and look at it. There are very specific instructions for how you have to do it, but the main thing is you have to build rapport with your patient before you just start saying, do you understand what your prescription says? I mean, you want to get to know the person first before you just hit them with the questions on the brief, because the questions, therefore, are like, do you ever have trouble taking your medications? Well, if you've just walked in and you've just met them and they're already feeling high anxiety, they might tell you yes, when in reality they don't. But if you build a rapport with them, and that's why those community health workers are so very important, because they are the key to helping us navigate the communication with our patients. There's also a scoring tool for the brief that you'll find in that resource section. The newest vital sign is also found in that section. What I'll tell you about the newest vital sign is that it is a wonderful, wonderful tool for determining numeracy skills. But it can be very intimidating because it requires you to look at a nutrition label and calculate math to give an answer about how many carbohydrates, how many servings. So it's about 6 questions on that one. And every time I have ever used it, or any of my students have used it, they all have reported that before they even were started good working with the patient, they just shut down. They said, I just don't want to take this, because they feel very, very intimidated. I don't like for somebody to stand over me if I'm being asked to calculate. And I know how to do math pretty well, but it's sort of that sense of somebody's watching me and what if I make a mistake? So there are populations that this is a great tool to use, but not all. So look at both of them. There are many, many more, and you can go to the CDC website, and there's a plethora of information in the CDC section for health literacy that gives you all kinds of information about how to assess individuals. So these are individual assessments. The NAL and the NALs that we talked about earlier, those were population assessments that gave us a snapshot of the entire population, but these are actually done with individual patients on an individual basis. And that's our references, and I'll stop for just a moment to see if we have any questions.
So I do have a question in Alabama, we have a lot of different community health worker models going on right now, and we have a grant where we have several community health workers working in communities, and we have several represented here. And so how do we have them best help the patients within the community health worker model? Mm-hmm. So what are you seeing and how they're being used, for example, in diabetes or cardiovascular?
My assumption is that when you work with them as a community health worker, at some point in time, they have to fill out some forms. Is that correct? Yes. Okay. When they fill out a form and there are a lot of blanks or there are a lot of misspelled words, that is a big red flag that they have low health literacy or limited health literacy. So that is a real easy way to determine, and you don't want to bring it to their attention because that just makes it worse. You want to take the form back and say, let's go over this again, and there's just a few other questions I have because they may not have been able to read it, the reason they didn't understand it. It's not just numerical issues that we have, it's reading and comprehension. And some of them may have poor vision and not have corrected vision. They may need glasses. There's just so many reasons that we have to take into consideration, but I always tell folks that I do in-service for, or when we're working with those that are trying to learn more about health literacy, that front desk clerk can be the most important person in your entire office of a private practice. Because if they get forms turned into them that are not complete and have many misspelled words on them, that needs to be flagged for somebody that needs a lot of extra time spent with them. And sometimes providers will complain that it takes too long. it's taking a lot more time in the long run, because when they come back over and over and over, but they're not considering that day. And so we've got to really look at new models of care that allow for there to be reimbursement for specialized health literacy providers that can spend the time with the patient. And it can be a community health worker, it can be a nurse, it can be an LPN nurse. There's all sorts of providers that could be doing this. But our CMS model doesn't allow for reimbursement of that right now. So, and our private insurers do not either. And again, you have that 12-minute visit time allotment that usually impacts your ability to really be able to explain everything to them. Other questions?
Yeah, I'm just wondering about websites for the public. I know it's not about providers, but like, do the CDC and like WebMD, what level?
What to go to? The CDC has amazing resources for anything that you want to find out about health literacy. As far as WebMD, it is the pinnacle of what the health literacy community believes that you should be referencing for your patients, because there's so many websites that have miscommunication. Now, one thing I'll share with you is that we know that most every hospital now has an electronic health record, right? Well, I did a study about 6 years ago, and when I was working with these 9 hospitals in Alabama, but we could only use 8 of them because one was a children's hospital, so we couldn't use that data because they don't report 30-day hospital readmissions. But I, not working in the hospital, was not aware of the fact that all of these proprietary electronic medical record companies, almost every one of them, have a button you can push for low literate patient or regular information. And it's the most important thing you can teach your nurses in the hospital when they're doing discharge teaching, that look for that simple and easy to read, plain language discharge instruction button, because almost every electronic medical record company does provide that. But most of the time, our nurses are in such a hurry to do the discharge and get another one in and another one out. They have not necessarily been taught that, or they don't remember where it is, and it's, they're busy. But that's a good question.
We have a lot of community health workers in the audience right now. Do you want to share any examples where you've had some situations come up, and how, what challenges you all might have in talking with people who have different chronic illnesses? Does anybody want to share anything?
I am fairly new in this environment, but it's something that does passion me, and I have had a lot of experience. Recently, I just came back from New York. My aunt has been in the hospital. I had to visit 3 different hospitals, and they require, for somebody that doesn't speak English, they do have the services for translators. They have like
Yes.
these little TVs that they bring to you, and they have to log in. Is there any certain standards or that they use? Because most of the time they are more thinking of their call model and to hit their requirements for them being monitored than actually what they actually trying to translate to the patient. And that gets really, really more confusing. I do speak English and Spanish, so I had to witness the way how the patient gets very confused on what they're trying to transmit to the patient.
Yeah.
I mean, we have to understand that the patient is there because they're sick.
Yeah.
They're going through a lot. Their mind is not probably in their place, and they try to use fancy words or hit their call model or hit these standards and criterias than actually putting themselves in the patient's position and try to explain as easy possibly for them to understand to what exactly. I was there, and they have to use it, but I was also telling them, I was like, this is not what the doctor is telling. This is not what the nurse is trying to tell you. And I was there caring for her, and I was able to correct that. But is anybody actually looking after these and understanding?
By law, yes, they're supposed to be. You brought out two very important topics. One is when the providers come in and they're talking really big language. We should be talking to the patient. And often when we go into a hospital room with doing our rounds with the whole team of doctors, nurses, and social workers and whatever, everyone is talking to each other and the patient is lying there and nobody ever asks the patient, what do you think about this? So that is really important for all healthcare professionals to begin to have that practice. And translators are required by law in each healthcare facility that has federal funding. Some are better than others. There are many different types of technology that are used. And when you mention the Hispanic population, there's so many different dialects. That's where it begins to get really, really challenging. So, we're going to get to that a little bit more in the next module. But for right now, I think we're going to take about a 5-minute break, and we'll be back with you in just a moment. Thank you. Welcome back to our Health Literacy Training Session, Module 2, that will focus on language, diversity, culture, and equity. Our objectives are to identify patients with special communication needs and at-risk groups of people with the greatest needs, including hearing and sight impaired. We'll discuss how to care for patients' cultural, religious, or spiritual needs and address culturally sensitive information, as well as address principles of working with translators and interpreters and how to avoid miscommunication. I want you to just look at this and think about if we shrunk the Earth's population to 100, you would have 57 Asians, 21 Europeans, 14 North, Central, and South Americans, 8 Africans. And of these, 70 would be non-white, 30 would be white, 70 would be non-Christian, and 30 would be Christian. So when you consider the world and global population, and health literacy initiatives are very globally in nature. We have got organizations that work all across the globe working together with the researchers in America. But we have to get out of our silo of thinking how we do it in America because we have not been doing it that well. And the statistics bear that out. We're probably the least healthy nation in the world, and we spend more money than anyone else on our health care. So what are we doing wrong? A fact check. What % of adults in the United States are known to have basic or below basic health literacy? So those two groups combined. Anybody remember from our last session, or what's close to it? It should be 36. It's not going up high enough. I'm sorry. My little star fell down. It should be a little bit higher. And then unique communication needs. At the first visit for a patient coming into a new clinic, assess them for their health literacy level. That is so easy to do. Remember, we talked about forms. If they don't fill out the forms completely or they have misspelled words, they may not understand what they're reading to even answer it. So I always encourage health agencies that have private practices to have a frontline worker, the person that intakes the patient, to take someone to a separate room and work with them and ask them the questions and fill it out if you need to, but then flag them as a person or patient that is in need of more intense educational opportunities related to what they're being cared for. Does the patient have a sensory or intellectual impairment? Sometimes we know that and sometimes we don't. Family members come in come in to be very helpful in that. Ask them what their preferred language is. I mean, just ask them. You know, they may speak broken English, but they may prefer to speak Mandarin or Spanish or Hispanic language. Help me here. Yes, Spanish. So, you know, there's so many different languages, and of those languages, there's so many different dialects. But you know, because of the translation services that are available to most all providers in America now, we have the opportunity to get them people that can help us understand them, but ask them what their preferred language is. Are all admission forms complete? And what is their race and ethnicity? And what is their background? And most of the forms that I've seen have got lots of information on their demographic information that even go into what grade level did you complete. And during a study I had, I'll share with you some of the most health literate individuals that were in my study had the lowest level of education. But it was because they had lived with diabetes for 40 years, and they knew exactly how to take care of themselves because they had learned what their language was, and they used different, you know, they used high sugar instead of diabetes. So there's a lot of learning needs that we have as providers as well as our patients need. Unique communication needs. Before you begin, try to build rapport, a relationship. We talked about that a little bit earlier. Lack of eye contact is a warning sign to you. Enlist families to gather more information and help you, because when somebody is not making eye contact with you, it can mean so many different things, and we don't have time to go into that today. But you want to be able to talk to that individual face to face and really address them. Do they have any assistive devices? Do they need glasses? Have they even been tested what their hearing or their sight is? How long has it been? Continue to build the patient-provider relationship as you complete the assessment. And I've seen videos, I'm sure you have, of the EMRs that when they first came out, providers going in and sitting there and holding the laptop in front of them the whole time, and the patients over here talking, they're asking questions. That doctor or nurse never even makes eye contact with them. And that's really, really not a good practice. And so consider, if you're working with an electronic medical record, the value and importance of looking at that person and really gathering the data and then entering it into your electronic medical record. Communicate information about unique patient needs to the care team, and consider the red flag warning signs on their chart and flag their chart. There's one study out of Florida where a nurse actually did an entire floor where they tried out the brief, and at the end, it was so successful, they had in their electronic medical record a new flag that came up if somebody had been tested for low health literacy, or been tested and found to have low health literacy. They knew immediately, anybody that opened that record knew immediately that that person was having difficulty. So that is a great way to do it, but you'll get some pushback on that if you ask your provider to put that in their electronic medical record. Nonverbal communication. Eye contact examples. In the United States, through our culture, and we're also known as the Western culture, direct eye contact is mostly viewed as a very positive communication skill, particularly when you go in for an interview or when you are trying to make a connection with somebody to really understand what the other person needs or wants. Direct eye contact is what Americans do. But in many countries, eye contact is not appropriate and is very frowned upon. And so we don't have time to go through that list today, but it is, if you have some of the Asian population, some of the Hispanic population, there's just many, many cultures that really are very patriarchal, and most of the time the male of the family will speak for them, and the female will just keep her head bowed, and it's not disrespectful to you, it's just their culture. Culture fact check. Which of the following characteristics is the best independent predictor of a person's ability to understand health care information? Educational attainment, my star hit the right place. That's the best indicator, because if they absolutely did not even get out of the 6th grade, we know that no matter what their ability could be, that they come into the picture with a very big disadvantage. At-risk groups, anyone is at risk for miscommunication. All of us saw it during COVID-19. We continue to see it. Social media has driven it, and I don't know where the end is in sight, and I doubt it is. But those with the greatest risk are those born outside of the United States, the aging population. They tend to, you hear these stories about how the aging population get calls and they're tricked by scammers and they'll send money and all kinds of things. So the aging population really will believe a lot of things that you tell them and not check it out at all. So make sure that you pay a lot of attention to your elderly patients. Patients who ask very few questions, the reason they are asking few questions is not because they understand everything. It's often because they're intimidated and don't know how to verbalize what their needs are. And if they're impaired memory or intellectually, you probably will have that on your record. And then again, if they speak another language at home, English may be a second language, so find out again what is their preferred language, and then low levels of education. Case scenario, Raul. Raul was a Spanish-speaking 18-year-old young man. He stumbled into his girlfriend's home and told her he was intoxicado and collapsed. He had previously had complaints of dizziness and headache, and the paramedics interpreted that to mean that he was intoxicated. The intended meaning and what he was trying to tell his friends was that he felt nauseated. When they got him to the hospital, he was put on a gurney, and they looked at him and sort of halfway assessed him, put him out in the hallway. And after 36 hours, he'd had a workup for a drug overdose, alcohol abuse, and was comatose by the time they did an actual workup on him. His diagnosis was intracerebral hematoma with brainstem compression and subdural hematoma secondary to a ruptured artery. The outcome was a $71 million malpractice settlement. That article is in your resources. Please take time to read it. It was written by a physician, and it was in the New England Journal of Medicine, and it is a wonderful article. Cultural beliefs may change how people think and feel about their health, when and from whom they will seek health care, how people respond to suggestions for lifestyle change. They may have very different beliefs about what interventions they're willing to use, particularly with birth control and those types of things that are invasive or can be invasive, how people follow directions and take their medications. So culture is a very big part of health literacy, but it's complicated. And so if you work and live in an area that has a specific population that's more prominent that you deal with, I encourage you to go back and find out more about what those cultural beliefs are. Culture differs in styles of communication, the meaning of words and gestures, and discussions about the body, health, and illness may be very uncomfortable for some people. And be aware of personal space. Now, we've all gotten used to 6 feet apart, but that will eventually go away. And I remember the days of going into different events where you were crammed in like sardines into a little bitty tiny area trying to get into a stadium or a movie theater or whatever. That's way too close. But also touch. I've always been a person, I'm a nurse, and I've worked in the hospital, and I've been in private practice, and I've done a lot of things working with students and patients. And I grew up in Alabama, and the southern way is not always the best way, but I tend to put my hand on somebody's arm if I'm asking them a question and they seem upset or concerned, and that's not always the best thing to do. And so touch is very offensive to some people. So know your patient before you begin to become too close to them, and determine when you think it is appropriate based on your observation and their interactions with other people. So I love this because it's kind of like a journey. There's no easy way to learn all of this. It is something that, let me go back to that. That should have my journey on there. Isn't that a beautiful scene? You know, and you think about when you go on a trip, you go on that trip and you come back and you have all the wonderful memories. But for people that study health literacy or patients that are suffering from health literacy, health care and health sustainability is a journey, and it builds upon your past knowledge, your past experiences, and sometimes you're so afraid of what lies ahead, you get stuck and you just really can't move forward. So empower your patients through advocacy and teaching them exactly what words mean. Many of them may not know how to say it or how to use their medicines or care for themselves, but if you spend the time with them, most of them have the capacity to do that if enough time is spent with them. And you will be their best friend. They will never forget you for that because you showed that you really cared. So gestures, hand gestures. I love this slide because it gives you a couple of different countries, United States, Japan, Brazil, and Russia. And, you know, that means okay in America, but in Russia it means zero. In Japan it equals money, and in Brazil it is an insult. And so eye contact is just like that. And I've had patients through the years when I've worked with non-English speaking patients that I've really had difficulties when I did try to make eye contact. And I found that when there is a family member close by, that can be very helpful. But be cautious about using family members because they may not always be translating it the correct way that the patient wants them to because they don't want to embarrass them. So that's why it's always good to have another interpreter. Context, also known as the situation. Different situations with different cultures can cause people to get very confused. There are three critical factors of health literacy: comprehension, understanding, decision making. And I would go one step further and say mobilization, because you have to have all three of those to be able to act upon the information that you have. Religious and spiritual needs. Now this book that is on the screen is, you may not can see the title, but it's called The Spirit Catches You and You Fall Down. And for any of you who have ever seen the movie Gran Torino that Clint Eastwood starred in, it is a wonderful movie about the Hmong culture, and they do not make eye contact, and they have many, many different cultural beliefs. And it's a true story about a young girl who was born in America. Her mother was pregnant when she was loaded onto a cargo plane and flown to America when the fall of Saigon occurred after the Vietnam War. And the challenges that this family faced were unbelievable. And just to give you a brief synopsis, they took her home and she began to have grand mal seizures, and they thought that she was inhabited by some great spiritual God, and this was a gift to them. And when they took her to the hospital and she was having seizures, the staff were mortified because they were like, oh my goodness, you know, you've got to treat this. So they did treat her, and she would be flat, and they didn't like that when they'd take her home. You know what seizure medication can do. And so there was a tug of war continuously going on between the family and the providers until one day she was put into custody of Health and Human Services, taken away from her family, because they were viewed as being non-compliant when they truly didn't understand, and the healthcare system had not understood them. And there was one physician named Dan Murphy who took the time to study that culture and learned exactly why they felt the way they did. And if it weren't for him, she probably would have died many years earlier. She recently passed away a couple of years ago, but had a very challenging life and would not have if there had been some direct communication with everyone understanding, being on the same page. So that's a cautionary tale. But that book is wonderful. You can get it online for free. You just have to type in the words, and there are lots of places you can find it. It was a clash of cultures from the time of delivery to the rest of her life. Years of miscommunication and misunderstanding, and all involved suffering for Leah Lee's family, her caregivers, and the system. If it were not for that physician, what would have happened? Do you have the dedication to be that one? And I want you to think about the power of one person, and he was that one person that advocated for her. All of our patients need advocates, and the community health worker community is really the greatest advocates our patients can have. Title VI of the Civil Rights Act was signed in December of 2000, and the Federal Office of Minority Health developed standards for what now is known as CLAS. And it basically is culturally and linguistically appropriate services. And it is required by all hospitals or any agency that receives federal funding to implement CLAS standards. And it is meant to advance health equity, improve quality, and help eliminate healthcare disparities by establishing a blueprint for health and healthcare organizations to implement and provide culturally and linguistically appropriate services. So that big, long sentence basically means we're required to do this. And agencies can be penalized for this if you don't do it. That is why you see many, many more translation services that are of higher quality than what we saw before the year of 2000. Because when I was first in practice in Birmingham, I remember seeing patients that did not speak English, and some of the technology we had to bring in interpreters were by telephone that, they would be, I wasn't sure where they were in the world, but the connections would be bad, and it was just really challenging. But most all larger healthcare systems now have excellent translation services that are there, but you just need to find out where they are and use them. Services that are respectful of and responsive to individual cultural health beliefs and practices are encouraged. Ask what their preferred language is, health literacy level, try to determine that, and then gauge for yourself what their communication needs are going to be. Services should be used the same way by all members of the organization and healthcare team, regardless of what size it is, at every point of contact with the patients and the families. How many people does a patient go through from the time of coming to the hospital to the time of leaving? Think of all the handoffs that they have. And if we're not communicating with each other in a plain language way to explain exactly what's going on and take the time to do that, you've seen that, I don't know what the name of the game is, where somebody whispers something and it goes around in a room, and then by the time it gets back to the person that started it, it doesn't even have any it doesn't even compare to what was actually said. That's how it can be for patients in healthcare systems that are not properly handed off to the next group that's going to take care of them. The CLAS mandate is Standard 6, and it says that healthcare organizations must assure that the competence of language assistance provided to limited English proficient patients and consumers by interpreters and bilingual staff is available. Family and friends should never be used except upon the request of the patient or consumer. And I really discourage that, and never use children, because children are so embarrassed when certain body parts are talked about or discussed. And it's not fair to put them in that position. So take the time to find out who they need to come in to be that translator. It may take a little bit longer for them to be seen, but you can go and see the next patient while you're waiting for that translation service to come in. So who can you use as an interpreter? Individuals who've had their language skills assessed, who are trained and successfully evaluated in skills, modes, and ethics of interpreting. And there are certifying agencies, and they should absolutely be explored. And again, avoid family and friends, minor children, volunteers, patients and clients in the waiting room. I have seen that happen. Not so much recently. That's somewhat gone away. But it happens from time to time, especially in an accident. You know, if you're on the side of the road and there's a terrible accident, people come up. That's going to happen, but that's probably when it might be appropriate, but otherwise it's not. Language assistance options include trained staff who are certified or on-site interpreters that are usually employees of the organization, and they have specific interpreter duties that are assigned to them. Contract interpreters are usually paid for by the encounter, not the employer, but used on an on-call basis. They may be virtual, by phone, or secured computer. And the ones that I have utilized recently are excellent. Because using family, friends, minor children, volunteers, strangers, or other patients exposes the facility to a great deal of liability. And you can look that up, and it is tremendous. It ties in with that 30-day hospital readmission penalty. It may result in a breach of confidentiality, and we know that, what does that do? That breaks the rules of HIPAA. And we can be fined seriously for that. It may cause the patient to withdraw and avoid sharing critical information for their condition, and the entire reason for them coming has been voided because they're not getting what they need and they leave without being properly treated. And it may result in additions, omissions, and changes in the content. So, again, anytime you take a new job or go into a new environment where you're going to be working, make sure you ask, where are your interpreted systems? Who are your interpreters? Are they in-house? Show me where everything is, where I'll know in case I need it. Cultural competence, how it can influence care, is unbelievable. Patients' fear of being misunderstood or disrespected is much higher than any of us can imagine. Providers are not familiar with the prevalence of conditions among certain minority groups, and that can be a challenge. Providers may fail to consider people who differ in their responses to medication, and we see that a lot. Different populations and with our genetic sequencing now, we're kind of beginning to understand why and how that looks, but people don't, and everyone in this room could be given the same medication, and probably most everyone would have a different reaction than the other person. So one size does not fit all. Providers may lack knowledge about traditional remedies leading to harmful drug interactions. And I bring that up because so many cultures use a lot of herbal remedies, and they can really be challenging, particularly if you're going in for surgery. And caution, caution, caution. Make sure you find out everything they put in their mouth. Don't ask them what medications you're taking. Say, what do you put in your mouth every day that you think makes you feel better? Tell it to me like I'm a fifth grader, as Denzel Washington said in Philadelphia Story. And so patients may not adhere to their medical advice because they do not understand and do not trust the provider because they haven't given them the time to build a rapport. And particularly if they're somewhat insulting, and I've seen it at times, patients being blamed for being non-compliant. 99.9% are not non-compliant. They didn't understand the instructions, or they would not have driven 8 hours to have a colonoscopy and had a Big Mac right before they came in. You know, they didn't understand the instructions. It's not that they're non-compliant. Providers may order more or fewer diagnostic tests for patients of different cultural backgrounds. That may or may not be appropriate, but consider that whenever you're looking at cultural competence. Outcomes for providers who are culturally competent mean more successful patient education, an increase in patients' healthcare seeking behavior when it's needed, and they don't delay, and so they come in at the appropriate time. And it allows for more appropriate testing and screening with fewer diagnostic errors, and it decreases drug complications. Patients follow directions and medical advice more frequently when the provider and the patient understand each other and are culturally competent about one another. And it expands choices and access to high-quality clinicians. So I love this little slide, and I can't read it from here, but I'm sure you can on yours. But it's really sort of a storyboard of what someone, it's miscommunication. It's what someone told another person that they wanted them to build. And in their mind, the first one on the top left is what their image is of what they wanted. The second one is what one person did. The third one is a little different too. You know, you can see it keeps going over and over and over until you get to the end. And every one of them are different. And that just is an example of how miscommunication can happen. The 4 in 10 U.S., the rule of 4 in 10 U.S. adults reported avoiding medical care because of concerns related to COVID-19. This is a slide that we won't spend too much time on, but it's something that is very important for us to talk about. Someone asked earlier, what resources are the best to use? Don't go on the internet and just type in COVID-19 myths and facts. There was a very prominent women's health nurse practitioner that was sharing her opinion that COVID-19 vaccines caused infertility, which is not true. But there were so many people that had heard that and had seen that online, and that's just one example. So even during the pandemic, people who experienced a medical emergency delayed getting their care because they were so afraid of getting the vaccine. Vaccinations have been around as long as I've been alive and before that, and they have eradicated so many terrible, terrible diseases that would have killed off most of the population had they not been invented. So know your facts. The CDC is the best place to go for that information. Center of Disease Control. This is just a cute little take-home message. Texting is a brilliant way to miscommunicate how you feel and misinterpret what other people mean. I have been told that I'm a very matter-of-fact person when I send an email, and I've tried to be more cognizant of that because it comes across sometimes as being harsh. And I don't mean for it to be. It's just I answer a lot of emails during the day, and I usually just answer the emails. And I have a colleague who begins every email with, I hope you're having a wonderful day. And then when you answer her about her question, she'll send it back and say, thank you so much for the answer. I hope you have a wonderful rest of your week. I mean, she is so polite, and we joke about it with her a lot. But, you know, there's nothing wrong with that. Think about what you're texting and what you're sending in an email. And are you saying it where anyone could understand it? Because usually I will type out an email and I'll put it down for a minute, and then I come back and read it. I'm like, ooh, I need to rearrange this a little bit, because what's in my mind to say, I didn't want to lose that thought. So put that thought down, but then go back and revise it before you send it. Best resources, CDC and WebMD. Someone mentioned WebMD earlier. I believe WebMD also has, I looked the other day and I couldn't find it, but at one time they had a button at the bottom of their screen that also provided you with an easy to read version of any information that they have on their website. And anything you see on WebMD is going to be the most current and up-to-date fact that you could possibly find. And they are very similarly correlated with the CDC. Now, during COVID-19, we didn't know what we didn't know. And so there were a lot of erroneous statements made, and I don't have to go into that. We all remember some of them. But you know, we just have to be very cautious of making sure our family members, our loved ones, and our neighbors and friends understand when they go onto a website that's been created by a special interest group, it probably is not the best advice to follow that. The single biggest problem with communication is the illusion that it has ever taken place. That's a quote George Bernard Shaw said many years ago, and I've always loved it. And I think that concludes this section of our presentation. So we're at the 30-minute mark, 2:30, and I'm going to go on into Module 3. And this is on communication and the appropriateness of patient education materials. This is the module that I would really love to have all of you in person with me, because we would actually have an experiential learning portion where I gave you a consent form and you followed the directions for how to determine the readability and what grade level at which it is written. I created a health literacy course at UAB that was started in the early 2000s, still is taught to this day. I don't teach it anymore. But in my course, my students would tell me that was one of the most eye-opening experiences that they had, because they would go to different doctor's offices, dentist offices, or whoever, and they were required to get some type of discharge instruction or a consent form and analyze what grade level at which it was written. They ranged anywhere from 27 grade level. They ranged from about 20 to 27 grade level, almost all of them. And the ones that were simply written were poorly done. And we'll get into that in just a minute. So our objectives are to discuss risk populations for limited literacy and the importance of having a plan to avoid miscommunication, which will help us avoid another pandemic, hopefully. Understand how to develop plain language materials, which is what we just talked about, that are culturally and linguistically appropriate messaging. And discuss how to identify provider bias, working with all levels of healthcare workers, physicians to desk intake clerks. That will ensure provider bias is minimal, we hope. So miscommunication and misunderstanding. What is the difference? Misinformation, it is information that is false, inaccurate, or misleading according to the best available evidence at the time. My example earlier of the fertility issue is a good example for that. Misinformation can lead to provider bias, because when a person comes in and tells their provider, I am not taking that because I'm afraid that I will never be able to have a child, you can imagine how the provider feels when they know that it is not true and they fear for that patient that they are at risk. And that definitely impacts the provider and causes a wall to go up. Tips for talking with your family and friends and community about misinformation is to listen, empathize with them. My daughters sometimes will call me, I have 3, and they'll call me and they'll have some of the wildest things they've read on the internet about what we should not do. And I listen to them, and we talk through it, and I'm being empathetic to them. But in the end, I said, go check it out on the CDC website and see what they say about it. And usually I don't hear any more about it. Use inclusive language. Point to credible sources, and that's what I share with them. Go to the CDC or WebMD. And don't publicly shame anyone. No one deserves that, and no one should be doing it. A community toolkit for addressing health information, there is a link to that in your PowerPoint presentation, and it is excellent. If you are not sure, do not share the information that you believe to be absolutely true, unless you absolutely know that it's true. People with limited health literacy are susceptible, very susceptible to miscommunication that leads to avoidance of care, and again, will lead to provider bias. Plain language and provider bias. Well, when patients check in for a visit or hospitalization, during the intake through the discharge, every single healthcare employee should be alert the next provider that a patient may be at risk for limited health literacy to ensure provider bias. And what did we say a way to alert them is? Look at that intake form. That desk clerk has no idea how valuable they are. And often they are overlooked as the most important or one of the most important people in the entire office. Often patients are labeled as non-compliant when in reality they just don't understand the importance of vaccinations to avoid a pandemic and or other examples like the colonoscopy I gave earlier. Cues that a patient has limited health literacy is if they seek help only when the illness is very advanced. They're either stubborn or they don't understand how serious it is. And I've had family members that just did not want to go to the doctor. So it could be either. You may hear, I forgot my glasses, or I'm really tired. Can I do this later? Can I take it home with me? That's where going into that small private room with the patient and maybe another family member becomes very important, because you can actually help them fill it out and get all the information you need and then flag it with, I've told my offices I've worked with, I said, just get a red dot and just stick it on on their demographic sheet, and you'll know exactly who you need to focus on more. Like I said, it's not rocket science, but it can be simply done, but we're not doing it in a lot of instances. Lack of follow-through with tests and appointments is often because they don't understand calendars, they don't understand transportation schedules. There's just an unbelievable number of reasons that they may not go and get their test or follow up with appointments. Could be lack of insurance or their belief that their insurance will not pay for it. So be their advocate or get them with a social worker or community health worker that can walk them through that process to find out exactly why they are not following through. They very seldom ask questions, again, because they feel extremely intimidated, and they may pretend they can read. I have seen that more than I would have ever thought. And so that's a tough one, because you know that they're already feeling very intimidated and embarrassed that they can't read. That is when it becomes extremely important to bring in a family member. What about those folks that don't have a family member? You know, we have caregivers that come to office visits with patients, and they are very valuable for us to educate them on what exactly we need to be doing and how they can help. They have difficulty explaining medical concerns or how to take medications, and they have a very difficult time giving you a chronological timeline of when their illness began and how it had progressed. What is plain language? Communication that your audience or readers can understand the very first time that they hear, read, or see it. All healthcare workers must be knowledgeable of the signs of limited health literacy to avoid miscommunication that leads to the bias. But often our providers are not. On more than one occasion when I have taught not pre-graduate, but young men and young women that are in school to become a healthcare provider, when they have received some of my lectures, I've heard them say, it's not my responsibility I can't do everything for them. You know, I'm telling them what they need to do. They need to go home and do it. I said, well, I'll let you tell that to a jury one day, because when there's a consent form signed, who's responsible for what's on that consent form? Do y'all know? The physician, the provider. Who usually goes in and gets it signed? The nurse. How many times have you read a consent form that you didn't read any of it? I know I have, because it'd take you 2 days to read some of these things, and they're so written at such a high level. So when I've worked with hospital systems to simplify consent forms and information, I often encourage them, or I always encourage them, to have a simple form and attach it with the original form so that you can validate that you have given both to them and that they acknowledge that they have received both of them and that they understand, because that will keep you out of trouble if it ever becomes a legal issue. just look at this for a moment and tell me what you think. The first line says your physician has recommended that you have a colonoscopy. I won't read the rest of it to you, but I want you to consider that many of your patients that you feel do not understand or are non-compliant may see written language on a paper in this way. Could be from a learning disability, or it could be from anxiety. There's so many reasons. But a patient with low literacy skills perceives information differently than someone that is highly educated. So writing plain language requirements for federal offices, this was with the around the time of the Affordable Care Act, and it was the Plain Writing Act, and it was written into law. And it plainly spells out plain language and how it must be implemented in every every agency that receives federal funding. So you may want to ask about that the next time you're in the hospital or in an agency, that ask them if they follow the Plain Language Writing Act. This is a great little slide that talks about plain versus non-medical living room language. Now, I would dare say everyone in this room and online who went to school, when they came home for their first Christmas and their family knew that they had been in school to become a healthcare provider, came up to them and wanted them to diagnose them with something. And they thought, and you were so impressed with your own vocabulary you had learned that you come out with all these 5 or 6 syllable words telling them, and they didn't have a clue what you were talking about. And you might not have had a clue what you were talking about. But we don't have to talk that way. Providers really are guilty of this, especially young students, because they're very impressed with their new vocabulary. Analgesic, it helps you control your pain. Anti-inflammatory, it decreases swelling. Benign, not cancer. And let me share with you just a real quick thought as you finish reading these about positive and negative terms. Many times when you tell a patient that they are positive, that their results came back positive, if it is for occult blood in the stool, they may think, well, I got a good report because it was positive. No one takes the time to explain to them it's a bad result because you do have that, and it was positive because they found blood. So positive and negative, those two terms can be used and very misunderstood. So make sure your clientele understand what you are talking about. And I know y'all can read the rest of that. Creating plain language materials uses an audience-centered approach. So before you begin to create any materials, you bring together a focus group to determine what terms they most often recognize with different diseases. You want to know what type of information they already have, and organize your ideas. Use appropriate words that they would use, just like high sugar instead of diabetes. Use clear and simple sentences. The design is extremely important, and we've got a great slide coming up on that. Testing. After you get your documents or your materials created, test it on another group and ask them, did you understand what I was talking about? Because when we're creating things, oftentimes we think it's exactly what it is supposed to be, and often it is not. And so make sure you test it before you start using it widely. And then revise as necessary. Design easy-to-read patient education is what we've been talking about, and simply put, is about a 48-page document that is in your resources that is beautifully done. And you can find it in a lot of places if you'll just Google Simply Put, but you have a link to it in your resources. And it's got the key components and best practices for creating easy-to-read patient education materials. What matters is text. How many times have you gotten discharge instructions that was an 8-point font? I can't even read that with my glasses on. Visuals help tell a story, but we have to be cautious and not use cartoons. Patients that have been tested, adult patients that have been tested for developing materials, really recommend that you use photographs to represent and don't use illustrations. It's much more meaningful to them to see somebody that looks like them on a picture to get across the message. Consider layout and design, culture. Translations take your message further. Testing for readability. Always test for readability. Text appearance matters, and so you see the serif versus non-serif, and one has got a little curly Q on it and one doesn't. And believe it or not, this is not from the health literacy community, it's from education. They believe that serif, which is Times Roman numeral, is actually easier to read for most people because it's got those extra curly Qs that help you grip to that. There's a lot of debate about that, but that is what the literature says. I like 18-point font myself. Consider culture. Step one, know your audience. We've discussed that already. And the best way to make sure your materials are culturally appropriate is to really talk to that audience to try to reach them and find out exactly what they want to hear. How to determine grade level? Well, there are primarily two testing tools that are very easy to use. Flesch Kincaid can be done using a Word document in Microsoft Word. It can't be a PDF, it has to be a Word document. And if you go online and say, example of Flesch Kincaid readability statistics, it will give you a step-by-step screenshot of exactly how to do that. And within 30 seconds, you know exactly what grade level it is written at. You know the reading ease of it, and it is just a wonderful tool. But when it's a real short document, it's challenging that it doesn't do well with that. And if it's PDF, it won't do it, or unless the software is changed. The first time I gave a talk to a group of really important nurses to talk about health literacy, I thought, well, I've been using the SMOG all this time, and I know somebody's going to ask me, what does SMOG mean? And I thought, well, I better look it up, because I don't want to stand there and say, I have no idea what it means. And it stands for Simple Measure of Gobbledygook. That is the actual term that was used by the gentleman that created it. And you also have that in your resources. The SMOG analysis is one that you can use in the field. It is very simple to use. You mark off 10 sentences in the beginning, the middle, and the end of a document that's a couple of pages long, and you count how many syllables are in the words in those passages. And then there's a formula that tells you how to calculate what grade level. But what I would say to you is don't ever use any more than 2 syllables for a word if you can possibly help it, because that's where the reading difficulty comes in, is with multiple syllabic words. Before and after evaluation of plain language. So I shared with you, I taught a class and everyone had to get an informed consent or discharge teaching summary. And one of my students brought this in from Children's Hospital, and it is asthma discharge teaching. And she said, I said, how well does that work for y'all? And she said, well, we're wondering if we can do a better job. And this was my favorite example of the 15 years I taught that class, so I love to share it. This uses everything that is in Simply Put. There is not one bullet point or word on the second one that is not from the first one. It is formatted differently, and it is for children or adolescents that care for children. That's why it has cartoons. But look at the difference. You could laminate that and put it on your refrigerator and have it right at your fingertips whenever little Johnny or Susie start having wheezing episodes. Visuals help tell your story. One message per visual label with the caption. Don't load it up with tons and tons of instructions under a photograph. Be very simple and direct. Consider your white space. Photographs of real-life events of people and emotions are always more impactful. And that's another continuation of that. Simple drawings also may work best. An illustration of a drawing can simplify complex information and highlight key components of an idea. I have been in the room with physicians that are cardiovascular surgeons when they would explain to a patient about the heart chambers. And often they'll draw a circle and divide it into four quadrants, and the patients love it because it's simple for them to understand. So, this is an example of showing a procedure for drawing blood. And on the next slide, you've got a cartoon, and you're like, okay, well, that doesn't look as good as the first one about drawing blood. The doctor wants me to run a few more blood tests. Well, we don't want that to be in their mind. Cartoons may be good to convey humor, but this is not a humorous situation, so don't use cartoons for your adult audience. Your layout and design, we've talked about that. It's covered very well and simply put, and so I won't read all of this to you or talk to you about it. But just remember that health communication materials such as brochures, web pages, flyers, or posters should all be designed so that people are able to understand your main idea and know who the material is intended for. Most practitioners will tell you only use 3 points at any given time. 3 questions or 3 points, because that's about as much as a patient can comprehend and remember and carry with them. So do it in blocks of 3, chunk of 3. The layout design, this is another example of attractiveness and which one you would be most likely to want to use. And those are actual documents on the same thing. Images to illustrate. Image B is a great image because it takes image A, but it narrows it in to where that is in the heart, where your patient can understand a little bit better. Well, this is really going to impact my heart and blood circulation, but without that second illustration, they may not fully get it. These are our resources. Y'all have been a wonderful audience today. In person, and I am so thankful to have had the opportunity to visit with all of you online, and hope that this will inspire you to get more involved with health literacy and do the best you can do to care for your patients. Thank you. Do we have time for any more questions?
We have a minute.
Okay,
Do
we have a
any
couple of
questions?
minutes if anyone has a question.
Any questions? Okay, well, we'll be getting with our audience in just a little bit to talk a little bit more about some follow-up training, and also we would ask our audience that is virtual to let us know what kinds of training you might need with either health literacy or provider bias. And this concludes our program today. So I want to thank Dr. Dupree for being with us, and I thank you all for watching. Remember that you can refer back to this. The training and the resources are all on demand anytime. So have a great day. Thank you.